Yes,
I can hear you. I can
Okay.
hear you.
I just sent Scott a text message and said that we could hear him, but he apparently cannot hear us. So he's
Yeah.
probably going to try to get that worked out. So if we can just wait a moment for him.
Yeah.
Marilyn, can you hear me?
Yeah, I can hear you.
I can hear you too. Maybe you need to go out and come back in, Scott.
So we do have quorum, but until we can resolve. Oh, so he just left. So we'll wait for him to come back.
Andrea, can you hear me?
Yes. Yes. Can you hear
Okay.
us?
I can hear you now. Excellent.
Okay. Perfect.
Don't know what happened there, but
No, that's okay. We could hear you for some reason, but yeah, you couldn't hear us.
good thing I wasn't swearing at the machine. Okay.
So
Do we have a quorum?
We do have quorum.
Okay. Let's go ahead, since we're running a bit behind and we've got a lot to cover, to call the meeting to order.
Okay, so Member Becker? Member Bruni?
Present.
Member Kirkpatrick?
Here.
Chair Nielsen?
Present.
And Member Summers Armstrong? She is on.
Present.
Oh, thank you. So members of the public may attend and participate in the Southern Nevada District Board of Health Finance Committee meeting over the telephone. To join, dial 702-907-7151 and enter phone conference ID 852-606-137#. To provide public comment over the telephone, press star 5 to raise your hand during the comment period. When called upon, press star 6 to unmute your phone. Thank you.
Thank you. Let's move to item 2, which is the Pledge of Allegiance. Please stand and join me in the saying of the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Justice for all.
Thank you. That leads us next to the first public comment period. It's a period devoted to comments by the general public about those items appearing on the agenda. Comments will be limited to 2 minutes per speaker. Andrea, do we have anyone who would like to comment during this public comment period?
No, we don't see anybody online for public comment.
Okay. Noting that, we'll close the first public comment period and move to item number 4, which is the adoption of the March 23rd, 2026 agenda. Do I have a motion to?
So moved. It's Marilyn. So moved.
Thank you. And do I have a second?
This is Nancy. I'll second.
Okay, we heard Councilwoman Summers Armstrong as a second. All in favor, say aye.
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 Thank you. That's approved. Next item on the agenda is item number 5 is the consent agenda. The only thing appearing on the consent agenda is the approval of the minutes of the Finance Committee meeting of February 24th, 2026. Do I have a motion to approve those minutes in the consent agenda?
So moved.
This is Nancy.
Marilyn.
Motion.
Have a motion and a second. All in favor, say aye.
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 Aye. Okay, thank you. That is approved. Next is item number 6, report, discussion, and action. And that leads us to item number 1 is receive and discuss the Southern Nevada Health District poverty level guidelines and approve recommendations to the Southern Nevada District Board of Health for on March 26, 2026. And I'll turn it over to Randy.
Yes, sir. Good afternoon, Chair Nielsen and members of the Finance Committee. My name is Randy Smith. I'm the Chief Executive for the Southern Nevada Community Health Center, which is the FQHC division of the Southern Nevada Health District. And I'll be leading us through this presentation and the one immediately following. Next slide, please. So what we're looking at this afternoon are updates to the federal poverty guidelines and the associated federal poverty levels. These are the documents that we use to administer the sliding fee schedule. That's a requirement of our HRSA programs. The federal poverty guidelines are updated each January, and they reflect changes to the consumer price index. For this year, it's reflecting a 2.7% increase from calendar year 2024 to calendar year 2025. If we could go to the next slide, please. Once we apply that methodology, we update the federal poverty levels accordingly. And for 2026, this is what it looks like. And again, just to orient everybody, the way that the document works is on the left-hand side, going down the left vertical axis is the family size. And then across the top are going to be the income levels starting at 0%. You can see that this schedule takes us to what we call P4, which is for individuals with incomes greater than 200% of the federal poverty guideline. And based on where a family member might fall, based on their income and family size, they're placed on this schedule. If we could go to the next slide, please. This is a continuation of that document, but it's accounting for two of our other programs that have higher thresholds for when a sliding fee discount can be applied. In this case, we're looking at family planning, which has a threshold of 250%, and Ryan White, which goes up to 400%. And next slide, please. And pretty short and simple, something that we do each year. Happy to answer any questions anyone may have.
Do any members of the committee have any questions for Randy at this point?
Nope.
If not, I've asked for a motion to approve item number 1.
Mr. Chair, it's Marilyn. I make a motion to accept, right? We're going to accept and adopt
Yes.
the federal poverty level guidelines.
This is Nancy. I'll second.
Thank you. We have a motion and a second. All in favor, say aye.
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 Great. That motion passes. Next is to receive and discuss the Southern Nevada Health District clinical sliding fee schedule and approve recommendations to the Health District Board on March 26, 2026.
Wonderful. Thank you, Chair Nielsen. I'll be taking us through this deck as well. So again, the sliding fee is a requirement from several of our programs. This is where we get some of our requirements from Health and Human Services, of course, HRSA, and some of our other pass-through grants have similar requirements. Next slide, please. Looking at the HRSA side and looking at the compliance manual, the first thing I want to point out is that all health centers must operate in a manner such that no patients are denied services for inability to pay. And the way that we're able to put this into action really is twofold. First and foremost, the health center is required to prepare a schedule of fees or payments for the services that we provide that are based on the local prevailing rates and are designed to cover costs of our operations. Immediately following this presentation, you'll be hearing from DJ, and DJ is going to talk about our master fees, and that's the intersection between the master fees and the sliding fee requirements. The other piece that's important here is that the discounts must be designed in such a way that they account for a patient's ability to pay. And that's where we bring in the sliding fee, the FPL document that we just looked at, and the rest of our program to support that. Next slide, please. Again, so what we do here at the health center is we take the federal poverty guidelines and the corresponding federal poverty levels and apply that to an individual's family size and annual income. And that's what helps us to place them on the fee schedule. One caveat is that a full discount to individuals and families is required for anyone with an income at or below 100% of the federal poverty level. And the exception to that is we are allowed to impose what's called a nominal fee. This is a token fee. It's not based on any slide or any kind of methodology. And the other avenue, or excuse me, the other caveat with that is that not all programs allow for the imposition of a nominal fee. So we do have two programs, our Family Planning Title X program, as well as our Ryan White program, which do not allow for a nominal fee. So you'll see as we go through the presentation, those are set at 0. The other piece of this is on the other side of things is that there's a cap on when the sliding fee can no longer be offered. And that's going to be for families with incomes that are above 200%. Again, both Title X and Ryan White have higher thresholds, which allow us to offer a fee at a higher amount. Next slide, please. Just like any other business, we are required to maximize reimbursement. So this kind of comes in two ways. First and foremost, we set up our fee structure to assure that no patient is denied services due to their inability to pay. And then secondly, we are required to make every reasonable effort to collect those payments. So whether that's an individual on a sliding fee like we're talking about here this afternoon, or a patient with insurance, it's our responsibility to attempt to collect fees. Starting in calendar year 2024, we implemented sending patient statements, and I'll get to that in a little bit. For last year, you can see we raised or collected just shy of $39,000. That is a 33% reduction from what we collected in calendar year 2024. Now, the 24 data also included some catch up from calendar year 23, as this was a new program that was being implemented. And I believe we're also seeing some improvements in our front office in terms of asking for and receiving payment from patients at the point of care. Next slide, please.
So Randy, before you go on, so explain to me, so what do you think, why did we receive 33% less in collections?
I believe it's twofold. One is in calendar year 2024, which that data reflected the 33%. That was, we had just started using this, and that included some collections from the previous year, from calendar year 2023. So it wasn't just 24 data that we're looking at. We had a catch-up period. And then secondly, through training and support to the front office, I believe we are improving on our ability to capture and receive payment at the point of care, right, when a patient's actually checking in. So I think it's twofold.
Thank you.
Thank you for the question. Okay. So again, this is just what the program looks like in action from the perspective of a patient, right? So a patient is going to be placed on the sliding fee discount schedule based on their annual income and family size. Based on where they fall on that schedule, a charge is created at the point of care while they're checking in. We're asking at that point for our patients to make a payment. And one of three scenarios will occur. Either patient will make a full payment, they'll make a partial payment, or they may make no payment. And actually, there's a fourth scenario. A patient with a balance can actually pay their previous balance at the time of their visit as well. Regardless of what scenario occurs, no patient is ever denied service for their inability to pay. Patients with outstanding balances are sent a statement with a request to pay. And similarly, when they're checking in for a visit, if they have a balance, we're letting a patient know that there is a balance and seeking to collect at that point as well. Any patient that has an outstanding balance after 12 months, that outstanding balance is written off as bad debt. And I think that's an important distinction. We don't want patients not to come and see us because of concern of an outstanding balance. What's most important is that they come in to be seen and receive the care that they need. Patients are not sent to collections to recover outstanding payments. And we do at each of the health center sites have support through the county as well as through a local nonprofit to assist individuals to see if they may qualify for Medicaid, and if so, help them actually with the application process. And I think there's a question.
There are two hands up.
Okay.
Let's Nancy, do you want to go first? Sorry.
I think my colleague had her hand up first. I will
Oh.
defer to her and then I'll ask my question.
Sorry, Chandra, go ahead.
Thank you so much. So when you referred to writing off as a bad debt, does that show up on the patient's credit report?
No, it does not.
Thank you.
You're welcome.
So I have two questions. Is there any way to get the data by the type of interaction it is, whether they pay the full amount, whether they do a partial payment? And then my second question is, do we flag someone, so say they have had a circumstance that prevents them from being able to pay their bill, do we flag that in the system so that, what do we do the next time they come in, and does the data show that we have some folks who just are kind of like frequent flyers in terms of not paying, or what does that universe look like?
Sure. So with regards to the first question, I'll have to get back to you on that. I'm not sure what capacity our system has to be able to discern, at a kind of a report level about whether or not somebody made a partial payment or has, various configurations, but I can certainly follow up on that for you. What I will tell you is when a patient is checking in, the front office attendant is going to know that there is an outstanding balance there, and at what point we'll ask for a payment. And if they can make it, great. And if not, that's okay too. Those payments would be sought to be collected through a patient statement. Again, it's just a reminder that there's an outstanding balance. Insofar as patients who are consistently unable to pay, that's okay. I think that's understood that there are going to be circumstances where patients do not have the resources to pay for their encounter. And so, yes, we do have patients who are coming in with multiple encounters who have not made a payment. If they can pay, wonderful. If they can't, we're going to continue to see them regardless of their ability to pay. And again, any outstanding balance after 12 months would be written off. Did that address your
Thank you.
question?
Yeah,
I see.
it did. Thank you.
I see that Marilyn has her hand up. Marilyn, do you have a question?
I do. And so Randy, so the real reason that we're doing this, right, is because we got dinged on our audit because the federal grant said that we absolutely had to at least ask, if nothing else. They weren't really interested in who was paying or not paying, but the federal grant, we got dinged twice, right, Scott, 2 years in a row on our audit because we didn't have this system in place. So we don't really care if they pay or not. We just have to ask the question because that's what the feds told us, right?
I wasn't there for those audits, but that sounds like it would be an area of concern for the auditor. We've had, since I've joined the organization, 2 comprehensive, what they're called operational site visits, and our sliding fee program has been found to be in compliance. But to your bigger point, absolutely. What we're here is, one is, just as I went in before, we're required to assess a charge, and we're required to have those charges be on the sliding fee so that we can lower them based on a family's income and family size. But no patient is ever denied for inability to pay. So you're right. We have to ask. If we're not asking, if we're not making an attempt, then we would be out of compliance.
Yeah, that's exactly my recollection too, Marilyn. So I agree.
Great. Okay, if there's no other questions on this one, we can move to the next slide. Okay, so basically what I just did is cover the mechanics and the why of what we have to do. So now I'm going to just tell you a little bit about what we do each year to make sure that our fee structure is in line with the local market. So we basically do this 2 different ways. One is we do a comparative analysis of other FQHCs in our community to see how our sliding fee structure aligns with others. And then we also do an internal survey of patients to get their insights about, how they're experiencing the slide, specifically about whether or not the communicated charges is preventing them from receiving services. And then finally, and this is something that we've talked over the last couple of years, for calendar year 2025, the health district had just shy of $6.8 million in sliding fee write-offs. Now, that's not cash leaving the organization. That is the value of care that's being provided. And that's a 28% increase over last year. And really, that's a reflection of, the health district and the health center really being regarded as a long-time, safety net provider in our community. Has a significant number of uninsured patients. And we had some great growth last year, and we grew in the Medicaid space, which has been a strategy, but we also grew in the uninsured space as well. And I will say, I think part of that too is we have some programs that naturally attract a higher proportion of uninsured patients, most notably our Title X family planning program, which has a pretty significant uninsured rate. I saw a couple of hands go up, so happy to address any questions.
Marilyn, do you have a question?
Thanks. So Randy, can I ask this question? What are we doing? Because I worry about the stability of the FQHC. So what are we doing to change that payer mix? And then the other piece is, I'm not starting, but I've always been concerned about insurance costs, and they are rising. So I'm wondering if all these sliding fees are not helping the insurance costs rise across the board, across the valley, across every single agency. Is there any conversation? Have you heard any national conversation on that? Because somebody's got to pay for it somewhere, which is why I worry about if you have a payer mix going, or I realized after several meetings with the health district and my seniors that Medicare doesn't allow you to work in their space, right? So then who's the next level of who? Because we've invested a lot of money and time over the last 5 years, and I would hate to see it get thrown out because we got crazy to work with.
Yeah, no, thank you for the question. First and foremost, with regards to the strategy of the health center and the health center governing board, for whom I also report to, we've invested a lot of energy into growing the Medicaid lives, and part of that starts at the foundational level with the various Medicaid MCOs and deepening the relationship with them. Over the past 18 months, we've been able to have a very regular cadence with each of them, whereby we're meeting on a regular basis. We're looking at the number of Medicaid members that are being assigned to our practice. We're engaging with them for help in connecting members to our organization. Internally, we've created some additional touch points as well. When we get, each month we get a list of members that have been assigned to our practice. And so we'll go ahead and attempt to reach out to them, to engage with them, to welcome them into the practice, see if we might be able to set up that first visit with them. We're also doing something on the back end as it relates to care gaps. You might be familiar with the term HEDIS, which is basically a compendium of various, mainly preventative health measures that the MCOs are looking for each of their providers to close. And so we're reaching out to those members as well to say, you've got some open care gaps. Maybe there's some cancer prevention screenings that need to be conducted, and trying to bring them back in. All told, we're chipping away, right? Last year we saw a 9% increase in the number of new Medicaid members assigned to our practice. That translated to an increase of 4% more Medicaid visits occurring. We continue on that march really through February of this year. We're tracking at our best progress in this space ever. The most members ever assigned to us and the most members ever being seen. Insofar as just the volume of the uninsured, it's a concern from operating the business in a sustainable way, long-term financially. right now, we're not seeing paying patients either with Medicaid or commercial products being squeezed out because there's not enough access to see them because that access is being consumed by our uninsured patients. But it is, something that we're concerned about, right? We're definitely doing the mission part of this work, right? No patient is being denied services for inability to pay. But we have a mind on trying to grow the Medicaid space, which is where the PPS reimbursement comes in, because that helps to even out our payer mix and allows us to serve more patients in a long-term sustainable way.
Let me
So
just
let
let me just real quick just comment on what Randy's saying. Cassius Lockett, District Health Officer. I've been pushing Randy and his team in this space to increase the number of Medicaid clients we have and receive from the managed care organizations. They did push it 900 to 2,200, the most we've had. However, that doesn't mean we're seeing all 2,200. So they're pushing there. And then we have to make sure we have the providers to receive it. But in terms of the payer mix, 15,000 unduplicated patients against a panel of 2,200 Medicaid clients from the MCOs, including the new MCO CareSource. We're trying to work with everyone to try to increase that size. But we have some work to do also on the provider side to make sure we can receive and perform care for everyone. So trying to triangulate all of those activities together, and hopefully, it'll have an impact because again, we do get credit for the PPS rate. And then, as you suggested, Marilyn, Randy and his team, they're working on the pediatric line, and you're going to see that shortly in this presentation.
So can I just say this, Dr. Lockett, and maybe the county is going to have to step back from funding the whole state on Medicaid. We can't keep funding everybody, right? At the end of the day. And so Medicaid won't exist without Clark County, but at some point I can only fund so much. So I just want to make you aware that, at the end of the day, we can't subsidize the entire state close to $200 million every year. So be mindful of that Medicaid piece, because the county is starting to have hard looks at some of these conversations, because at the end of the day, it's not even sustainable for myself at this point, right? So between the changes in healthcare that we're seeing, that I don't necessarily think it brings more access to care. It just is more of a Band-Aid when we're trying to give access. But I feel like we need to maybe go to some of our commercial providers and say, every one of your children should be getting our sports physicals here. Everyone should be getting some of these other things. And Medicaid's a hard conversation right now, and especially when the county is taking it on a chin on many levels. We're done subsidizing. We can't. We too got to cut services, right? So I just think that should be on everybody's radar.
Yeah, thank you for that reminder, Marilyn. And HR 1 is coming. So we're watching.
Thank you. Nancy, do you have a question?
I do. I would, given that this is a federal grant, I assume that the data reporting requirements are pretty robust. And so is it possible to get a breakdown of the users? And I'm just thinking, if we can, as we head to the, any legislative session or, talk with our jurisdictions, it would be great to be able to say, hey, Senator X or Y, 30% of the patients or the folks that we see, come from, your district, just in terms of, again, maybe building a case for public health funding and the fact that, probably most of our elected officials have residents or constituents who may avail themselves of the service. I think as resources, we have to take the harder look at sort of the resource allocation. It'd be good to know, is it primarily seniors? Is it teenage pregnant mothers? Just to, again, be able to figure out either policy levels or maybe, working with other partners in the community.
And thank you for the question. For clarification, so I heard it sound like location, perhaps zip code level information, as well as maybe age related. Was that, am I capturing
Yep,
what
age,
you're interested in?
yeah, age, race, ethnicity. Um, I don't know if you can, foster care, pregnant, teenage moms.
Okay.
Just trying to think about how to parse the data to get a sense of who, in fact, are we serving.
Sure. Okay, we definitely have some of that. There may be some limitations, but I mean, high level, what I can tell you is these are going to be individuals that are between 19 and 65, right? These are basically adult patients that are not on, they're not kids with insurance and they're not adults on Medicare. And unfortunately, this seems to be the truth for many FQHCs, right? These are the individuals that don't have other access points in the community, and those are the individuals that tend to come to FQHCs. But we did just file our UDS report, and I think we can pull together some data to be able to share with you and provide some of those elements.
Thank you.
Thanks, Randy. Chandra, do you have a question?
I do. Can you give us a idea of what you said something about there are care areas where we don't have physicians to fill those gaps. Can you give us an idea of what those specific specialties are where you are not, where we are short? And I agree, and while you're answering that, I just want to say that I agree with Councilwoman Bruni. The data will tell the story. I'd also like you to add, when you're talking to those about those folks 19 to 55 that you mentioned, are they all uninsured? Are some of them, do they have some Medicaid? Are they people who are coming to you with, insurance on the open market that doesn't cover very much? So are these folks like in the, self-insured, like small business owners who are nail techs or hairdressers who have to buy insurance on their own? And are they finding coverage or not? And are those coverage gaps sending them to us? And the last thing I'd like to add is, who is sending people? Are we just waiting for the MCOs to do it? Do we advertise ourselves? Do we have a marketing plan out there to send people with limited insurance to us as a viable option, right? So that we can gather some of those people before they get to UMC in crisis. Thank you.
Yeah, great questions. Yeah, absolutely. We do some outreach through health fairs and other avenues. In my experience, most of the Medicaid patients that find us by way of their insurance plan. In our conversations with the MCOs, patients are usually assigned to us based on their geography. And that's why we've invested a lot of effort in trying to grow our capacity with those MCOs. And it's also why I shared earlier around the care gaps. Part of what the MCOs is looking for us to be able to do consistently is close those care gaps, which certainly is a strong demonstration of quality of care. And so those pieces are all factoring into this. Insofar as the provider piece, last year was our best year ever in terms of the number of unique patients served. We served 13,431 unique patients. That was a 17% increase over last year. This has been a challenging year, as many of us know, with a lot of the uncertainty around funding. We've been on a partial hiring freeze. That work was done with 2 less providers. And so we've also invested a lot of time and energy internally in trying to be the best stewards of we can with the limited resources available to us and provide as much services as we possibly can. And I've been extremely proud of how the team has responded to that. We do have a couple of provider vacancies that we're working on filling right now. One of them is at Fremont, which has been a hard backfill for us. I think the biggest limitation is this. In the health center space, when you're uninsured and you receive services from us, what happens in our four walls, we can control, right? We have some limitations. If a patient's coming in and has advanced diabetes and needs to see an endocrinologist, they may be limited, we may be limited by the lack of availability of other providers in the community that will see a patient for cash, right? There's no requirement that a community provider offer the same type of sliding fee. And so what it means is that our teams tend to take on some, more challenging situations. And that's very true of all FQHCs, right? Many of our patients have been out of care for quite some time, have more advanced illnesses, and the resources to support them are more limited. And so again, we've got a fabulous medical director, Dr. Robin Carter, that joined us early last year. She's been a great resource in helping to support and grow the capacity of the internal team. And we do continue to work with those NCOs, do outreach events, and look for other opportunities to attract new patients to us. I'll just conclude with this thought. One of the things I've been more excited about recently is we've made some changes and created more open same-day walk-in access. And this has been done to try to overcome a high no-show rate, which unfortunately is also common in this space. And we're seeing some great success in this area and something that I'm really looking forward to the team building on. I think what it does is it really shows we're being responsive to the needs of our patients, not just asking them to use a traditional schedule-based system, but creating more opportunity for them to come in and see us when it works for them too. Okay, I hope I got to all those questions, but if there are others, please. We'll go ahead and move to the next slide though. So this is back now to the analysis that we performed. This is the external analysis that was conducted using these various FQHCs as a way to benchmark our fees against the communities. If we could go to the next slide, please. So this grid is taking those 9 health centers, and they are A through I across the top. We de-identified them. On the far left in gray is our health center. And then on the farthest left, you can see it's of 3 different slide levels, right? Lowest, highest, full price. So anything in black has a fee that's the same as what we provide. Anything in green is lower. Anything in red is higher. And then we also added this year just to show that these other health centers are responding to and their fees are adjusting as well. So we identified by way of a highlight if those fees have increased since 2024. And so as I look at our fee structure, I feel like we are very much in line with the market. And I also just want to point out, when you look at the full price, we've established our full cost for an office visit at $200. Our office visit includes basic labs, depending on what area that they're coming in for. And we're not quite sure how the other full fees are arrived at those other health centers. And you can see of the 3 different areas, that is the one that has the most variance. And so this is how we've structured, and why this is important is then that full fee is then how we apply the slide. So if we could go to the next slide, please. This slide is looking at the internal survey that was conducted. Happy to share that we had an increase of about 30+% in this last year. And really what this is showing, and you can see in the 2 sections, question 2 and 3, about how the fee is working for the patients. Overwhelmingly, it's working. It's not preventing people from accessing services, which is really what we're trying to do. Next slide, please. So now, taking all that information, now we're going to look at the slides. And as you see, there's very little that I'm proposing by way of change. But one thing I did wanted to make note, and this is to get back to Commissioner Kirkpatrick, your comment earlier. One strategy that we're deploying is trying to grow the pediatric line of business. At Decatur, we're actually going through and updating a little bit part in the waiting room to make it more children and family friendly. We've got an exam room that's set up that way as well. Dr. Carter is seeing pediatric patients as well as teaching our other practitioners to feel comfortable in serving them. And we're starting to make some modest improvements in this space. One thing that we're proposing for this year is really as a way to capture more pediatric patients is to provide sports physicals. And we're really looking to join the back to school activities that the district's heavily involved in each year to attract patients. Oftentimes sports physicals aren't even covered by private insurance. So this is an opportunity for us, while individuals are already here on site getting their vaccines, to be able to provide that service to them. I don't have it in the slide deck, but I can share with you that we have a very high patient experience score. In other words, patients that are coming to see us are rating us very high. And I think that's an outstanding attribute to have. And I think, you know, what we feel good about is if we can get them in the door, we can provide them a great experience, they're going to want to come back and see us. We've set this fee, you see it's $20 the whole way through. And the reason that we set it at 20 is because we're, one, trying to attract new patients. And two, you'll see that the $20 is set at the lowest fee level, the nominal fee level. So we know that that won't be a barrier to care for them. So this is just one example of a strategy that we're trying to do to grow the payer mix, to create more balance within it. Kiddos is, of course, is a good place to go because most kiddos, almost all of them, are going to have insurance. So that's what we're doing in the primary care space. Outside of that, you see I'm not recommending that we do anything differently here. Next slide, please.
Yeah, and
This
just
is
real
our
quick,
sexual health.
Randy,
Oh,
just real quick,
yes, go
Randy,
ahead.
on that sports physical, one of the things we're doing in terms of outreach, as mentioned by Commissioner Kirkpatrick, is to try and coordinate with our back to school immunization program during the same time to pick up clients. So it's going to be great.
Thank you, Dr. Lockett. Okay, the next slide. So this is for our sexual health clinic. It falls under the same slide schedule as primary care. No changes being proposed here either. Next slide, please. This is for our family planning services. So just to know, if you look at the P0, that's your second to the left column, you'll notice that the nominal fee for both the nursing and the provider visits is set at 0, and that's a requirement of the program. You'll also notice that their schedule extends beyond the 200%, so that additional discounts can be offered to families in that income space. Otherwise, as you see, no changes being proposed. Next slide, please. Same with Ryan White, same requirements around the nominal fee, and Ryan White has some additional opportunity to extend the discount for families at higher income levels, and no fees are being proposed to be changed here either. Next slide, please. Okay, so this is our pharmacy sliding fee schedule. So this hasn't had a lot of attention really since the implementation of pharmacy services, which I believe goes back to 2017. We are recommending one increase, and that's at the P0 level. Currently, it's set at $7. We're proposing to increase that $2 to $9. And, you know, and you'll see this bear out on this in the following slide. We've done some calculations, and there were some instances where our costs were exceeding the revenue being collected for these. And so there was an opportunity to nominally increase the fees to capture some additional revenue to keep us sustainable there. And then the next slide, please. Now this ties to pharmacy supplies as well as PEP and PrEP meds. So HRSA earlier this year issued some new executive orders, which was really meant to ensure that patients were not being charged by health centers in excess of what their 340B acquisition costs were, plus a dispensing fee that was determined at the organizational level. And so when we went back through that, we also had an opportunity to adjust our fees accordingly. And the fees that are in red are fees that are increasing. They still bring us within alignment with the executive order. And through our survey of the market, there's still extremely great value to our patients. And then finally, you can see at the very last one, we did not previously have a fee for DoxyPep. And so we went ahead and put that in there, and that fee is set at $9. And I believe that is the last of my slides. Okay, thank you all. And if there's any other questions, I'm happy to answer them.
Thank you, Randy. Do any members of the committee have any further questions? If not, I'd ask for a motion to receive the Southern Nevada Health District clinical sliding fee schedule.
So moved.
We have a motion.
A second, this is Nancy.
Given second by Nancy. All in favor, say aye. Aye.
Aye.
Aye.
Anybody opposed? That passes. Thank you, Randy.
Great. Thank you. Thank you.
The next item on the agenda is to receive and discuss the clinical master fee schedule and approve recommendations to the Health District Board.
So moved.
Do we have a DJ? Are you making the presentation on that, or who's
I am.
item number 3?
Yeah.
Yes.
Good afternoon, Chair
Sorry.
Wilson and of the committee. This is our clinical master fee schedule review. So the billing fee schedule is reviewed annually to add new fees or adjust existing fees. Annual review of fees allows for changes on a more consistent basis to stay in alignment with our local medical community prevailing rates. As Randy mentioned in his presentation, that is a requirement that we have consistent with the local rates. So these regular fee updates position SNHD for the potential benefit of increased reimbursement from our contracted insurances and Medicare. Uninsured patients would see minimal or no impact based on the availability of our sliding fee, which Randy went over, or a point of care discount. Next slide. So just to go over the methodology we use to review, we compare all of our fees currently utilized in SNHD operations to fees established in the Clark County local healthcare community. And we use the physician fees report, and we got the 2026 version of that. In addition to that, this year we actually received a companion document to that, which allows us to go a little further into some of the G code and the HCPCS codes. With me is Miss Donna Bust. She is our revenue cycle manager, and she is definitely the subject matter expert on what we're talking about right now. So she'll be able to answer any specific questions related to those codes. So we propose fee changes based on the comparison of the current fees to the 60th percentile in these resources that we use. And then also where fees are not available, we compare to Medicare reimbursement rate as well. If the fees are not represented in the physician fees report, we do an analysis of direct and indirect costs for services, medications, or ancillary costs to complete a form for a basis for our fees. The methods ensure that we are in a position to receive the fullest reimbursement possible from our payers. Proposed changes to individual fees are included in Exhibit A of this document. We have 247 fees with a change, and 20 of those are actually new fees. All other fees on the billing schedule remain the same. And then we did put a note in here that the qualifying G codes, we did have to set up codes to implement our shadow billing that became effective January 1st. The PPS rate, the way that's going to be, instead of us submitting documentation to receive the PPS rate, they implemented a process on January 1st where we have that actually is billed at the time that Donna's team does the billing. And so we had to set up some additional codes, so that was just a reference there. Now, if you'll remember, we moved to the 60th percentile last year. We started, when we started this methodology, we were using the 50th. Last year, we moved to the 60th, and that's where we stayed for this year. So it's more apples to apples this year. And then some fees on the schedule that you see will not, they actually are not utilized. but they were added into our list at some point, so they are in ECW. And so we do keep them current to the fee schedule in the event that we do start utilizing them, so that we don't have big gaps or an inconsistent jump. And I see a hand up.
Oh,
It's
yes,
me,
sorry.
DJ. No, it's all
Sorry.
right.
Go ahead, Mary.
DJ, I'm gonna ask the same question on the insurance. So my county employees' insurance went up 11% in less services. When this book is published, does anybody talk about the insurance cost that is rising for everybody else? I mean, I feel like we're contributing to it. Nobody's talking about it?
Yeah, no, the physician fee report is definitely from our community. So when we submit for the book, they gather the information from our zip code. And those are what the rates that we're seeing.
Well, I mean, I just am worried that we're contributing to the cost of rising health insurance. Because, 11% is a big jump for many of my employees, and less, I mean, what is the health district's people's insurance go up? I know it didn't stay status quo.
Yeah, I did, I want to say it was 5.
Yeah,
And it was
okay.
split.
Well, I just think it's a big issue somebody should raise sometime soon.
Yeah, Marilyn, I don't know. I'm sorry.
Go ahead.
Go ahead. No, I was just going to say, I understand what your issue is. It seems like this is very circular, that we keep raising prices and because it's the market, and then the market raises prices because other people are, it all seems very circular and designed to continue to have prices go up. I'm not sure I'm not sure how we can do anything or how we respond to that, but that does seem like what's happening. Chandra, do you have a question or a comment?
Yes. So I guess my question would be, well, maybe I need understanding. So, Commissioner, are you concerned that the health district's fee schedule is not rising in keeping with what the market is showing, and therefore is contributing to the rise in fees, or that it is moving and therefore part of the issue that we have with rising fees? And then I'll have a follow-up.
No, I think what I see is like supply and demand, right? So everybody's insurance went up, docs are asking for more, and then insurance rates go up again. So I understand why we have to stay with whatever this crazy book says to get our fair share, but at the same time, something's broke, right? Because as Scott said, we're all raising our fees, and then they go in and they do this report on what all the fees, what all the insurance costs are in the area, and then they go up again, right? So then the fees go up. So I think the system is broke, and I'm worried about contributing.
No, and this is Cassius Lockett again, District Health Officer. I just make a quick comment. It is a delicate balance, even for us. We're trying to pay attention to this, so when we talk about the 60th percentile, that means that, for example, if we have a select number of providers and the fee is between $80 and $200, the 60th percentile put us at around 140. So that fee of 140, we are above average, but not among the highest chargers. So we're trying to balance that. And as much as we can, because to your point, insurance rates are going up.
Exactly.
And may I also just add, if you don't mind, Chair, is that, our services are to the people who are the very least able to pay, and often don't have insurance. And so I think that I'm not certain that it's our folks who are influencing the increase in the fees. I think that we're trying to keep up with others who are driving costs, if I'm understanding this correctly. And I agree with you, Commissioner. The system is broken, but it is not broken from the perspective of the people that we serve. They're not breaking the system. It is, I believe, in my opinion, these large managed care companies are the ones who are really the drivers. They're the ones who are buying up our local practices, and those people are now becoming their employees and basically monopolizing the market. So, and then we have our small clinics that are trying to run as independent contractors against these huge behemoths. So I think that the challenge is huge, but I know that we are all concerned about the folks that we serve and making sure that our services are affordable to them, because when the folks who come to us stop getting health care is when we have a huge problem. When those folks don't get vaccinated, when they don't come in for flu, RSV and COVID, that's when we have a problem with outbreaks. And so it's a tough circle that we're in, but I'm proud to be working with this organization to at least do our best to serve the community. Thank you.
Well, thank you.
I'm not opposed to that. I'm just seeing, and I ask everybody, right? Every agency, every board that I sit on, every piece of legislation that mandates something, that at what point is someone going to have a real insurance discussion so that people can get the right care? That's all.
And I would note, I'm sure DJ is going to point this out, but once again, these fees that we're looking at, they are priced for the payers, for the people that can actually pay, for the insurance companies and so forth. For our clients, a lot of them are our patients that don't have the ability to pay, as Randy indicated, they don't have to pay. But these fees are very focused on the folks that can pay and the insurance companies that pay. So
that is spot on. That's what our revenue is pretty much driven by PPS rate, the payer mix, not the charges alone, as you pointed out. That's absolutely correct. The sliding fee revenue, bad debt exposure, all the things Randy talked about impacts our overall financial performance. Sorry, Donna.
No. And you're correct, Dr. Lockett. And I just wanted to add to that as well, that when patients come in that are underinsured, where they have a high deductible or something like that, we do apply the slide to them too. So it's not like if it comes back and their deductible is, $400, we can apply the slide to that because now they're underinsured at that point, to make sure that they're not getting, that large impact, even with their payers.
thank you. Go ahead, DJ.
Okay, next slide. So we do have the complete SNHD billing fee schedule is included after Exhibit A in your packet. Exhibit A is the fees that we have the current rate and the proposed new rate. And then the billing schedule that just has the fees after that only includes the new rate. So it does take on the proposed new rate for the other fees. And that is the remainder of the slide. We do have 20 new fees in this as we're expanding activity that we might be doing. We do have a few new fees, but the majority of them are adjustments from our current rate that we already had to a proposed new rate. If you have any question on any specific fee in the proposed fee, Donna did break them up by type. So we have medical and supplies, drug devices, I think we can roll through unless anyone has a question on a specific.
Well, I'll just say that some of the increases look crazy, but I guess they are what they are. So I'm not sure what we do about it at this point. So.
So, and I think you guys have heard us talk about this often enough. So this is the charge. And of course, we're going to have insurance contractual adjustments, which will bring that down. So, fees go up, there's a possibility our write-offs will go up. And so hopefully what we get out of that is a net increase in revenue that we get, even if it's, if the fee goes up $100 and the write-off goes up 80, that gap is what we're hoping to capture by keeping our fees in alignment with the local community.
DJ, or Dr. Lockett, can I ask on a specific one? I've heard from a lot of Medicaid patients that they're no longer covering the implant. Is that a true story? Are we covering it? Because
No, we do. They cover them. The Medicaid MCOs do cover them. Yeah, we were actually charging a lot lower than what most MCOs were paying. Mhm.
okay.
Yeah.
So they
No,
can't,
we are-
so if someone asks, I can send them your way, right? The health district?
Yeah, absolutely.
Marilyn, for what?
It's a form of birth control, but it's
Oh,
an
okay,
implant
okay.
that they
Yeah,
put in their
yes.
arm.
Implant devices, yeah.
Sorry,
Okay.
Scott, sorry.
It's a little out of my category. Anyway, all right. Do any members of the committee have any additional questions? If not, I'd ask for a motion to receive the Southern Nevada Health District Clinical Master Fee Schedule.
I'll make that motion, Mr. Chair.
We have a motion. Is there a second?
Second, this time in order, not out of order. Sorry, y'all.
No problem. Thank you. We have a motion and a second. All in favor, say aye. Aye.
Aye.
Thank you. That passes. Thank you. The next item on the agenda is item number 4, is to receive and discuss the fiscal year 2027 budget and approve recommendations to the Southern Nevada Health District Board. DJ?
Okay, so this will be our fiscal year 2027 budget, which runs July 2026 to June 30th, 2027. So our purpose here is to get our budget established so that we are able to get our appropriation in place and spend within the legal guidelines. Next slide. So just a broad overview of what is contained in this budget. So our staffing for fiscal year 27 is projected to remain static to the augmented budget that we brought before this board at 871.4 FTE. Our general fund revenues were projected at 124.4 million, an increase of 1.7 million from the augmentation that we brought forward. Our special revenue funds, our grants decreased by 42.5 million to 42.5 million in 27. That's a decrease of $14 million from our FY26 augmented budget. For the expenditures, our expenditures are projected at 127.4 million. That is an increase of 5.3 million from the 26 augmented budget, while the special revenue fund expenditures we're projecting at 48 million in fiscal 27. That's a decrease of 14.3 million from our augmented budget. And we will get into some of the details about what is included in that. For the special revenue funds on this, in general, I will say that our Senate Bill 118 funds expire on June 30th. And so some of that is related to that activity culminating this year and not carrying forward into next year. For the capital projects fund, our expenditures are projected at 2.3 million for next fiscal year. That is actually a decrease of $1 million from our fiscal year 26 augmented budget. Next slide. This is our organization chart. I think all the changes that we have, we're aware of at the time we pulled this together are included in this chart. Next slide. Okay, so here, this is our combined general fund and special revenue funds. And so you can see here, we are moving from $179.2 million total budget to 166.9. The major changes here are in the grant funds. We were at 56.5 million, and that will move to 42.5. The other activity, property taxes actually does show an increase here, and our licensing and permits stay substantially static, as well as the charges for services. Next slide. And then this is just a breakout by division, and so you can see with environmental health staying about 18% of the total. FUHC moving up a little bit from 24% to 26% of the total. Disease surveillance and control is actually decreasing there, and then community health is a decrease as well. Next slide. So the revenues our Clark County property tax revenue is expected to be at 43.7 million. And that was based on, that's still an initial estimate. We won't get the final until next week. And so that is an increase of 2.2 million over our fiscal year 26 amount, which was at 41.5 million. Our total general fund revenue is increasing from 122.7 to 124.4. That is a $1.7 million increase. That does include the property tax adjustment that I just spoke about. On the special revenue funds, we decreased from 56.5 million to 42.5. That is a reduction of $14 million. That includes a conclusion of Senate Bill 118 of 8.9 million. And if you recall, a portion of that is for the lab expansion, and those funds will be spent in this next quarter. And there's other lab expansion funding. If you recall, we had other municipalities contributing, and some of that funding will also be used this fiscal year, fiscal 26. So we won't have that in fiscal 27. Also, we have expiration of the state opioid response, $2 million. And then there's some other general reductions in our grant expenditures contributing to that overall $14 million reduction. Next slide.
Hold on, DJ.
Sure.
Marilyn, do you have a question?
I do.
Sorry.
DJ, can we talk about this property tax? So we at the county are seeing that recordings are down, building permits are down. So is this a sustainable property tax that you're building into your budget? I just am worried that you know, we're now below the 8% across the board at Clark County. So the last time that happened was in 2007. So we're really staying on top of it and we're trying to put some of that towards sustainable one-time shots. And then what account is it from the county that you get that property tax? Do you know?
I'm not totally sure. Dr. Lockett, are you aware which account we get?
No, I'm not aware. I've kind of had this conversation with Marilyn, but we can follow up and get that information.
Okay. Well, I'm going to see our finance people tomorrow. I'll ask them. I just want to figure out where it falls and stuff.
Right, and it is a smaller increase than we had last year. I think we're at 2.4, and then we had an additional adjustment. So, but that final, was based on the interim numbers that the state had provided, and so I think they just sent out the finals, and Jennifer at the county indicated that we wouldn't have the final number. So I guess it could go down based on their final rules. So that would of course impact, and we'd have to pick that up in the augmentation.
Well, I'm just more interested in budgeting it towards something that is not sustainable, right? So at the county, we budgeted whatever extra that we had towards our capital projects because it's a one shot, right? So I just want to make you aware of what we're seeing at the county.
Absolutely. Thank you. Next slide. On the expenditure side, our augmented budget is at 184.5, and we reduced to 175.4. Our contractual stays fairly static. You can see the capital is a change from 11.4 million to 4.7 million. Again, that is the runoff of those funds that we will be doing on the lab expansion, the majority of that. With our salaries, a note here is that the salaries in the fiscal year 27, I'll have some slides on some detail on that. These do include all of the positions. So the fiscal year 26 budget would not include all of the positions because a half a year had elapsed by the time we took the augmentation. And so only half of the year for our vacant positions, whereas the 27 budget actually contains all of the full year. Next slide. And then this is the breakout by our divisions. You can see that we have primary health and preventative care stays relatively, it goes up slightly, 800,000. Environmental health is up slightly, 1.2 million. The FQHC also up 2.7 million. And community health is actually down in this case, as well as administration. And since this is a combined budget, that the change in administration does include that lab expansion activity. So that is included there. Next slide. Then this does not include transfers between our general fund and special revenue fund. I will show you a separate activity for that. This one does include our cost allocations just to show the impact on our divisions. Next slide. Okay, on the expenditures. So our general fund employee salaries and benefits for fiscal 27 total 84.3 million. That is an increase of 5.5 million or 15% from our fiscal year 26 augmentation. And that will include at the time we put this together, we had 75 vacant positions. That would be an active recruitment pending on hold status or on hold due to the hiring freeze. And that those were included in the fiscal year 26 augmented budget at a reduced expenditure level, so only for a partial year. And so that will pop back up for 27 because we put the full year in. The changes in the status of the position will be included in future augmentations. So if they remain unfilled, they will become part of an adjustment at a future time. Part of that fiscal year 27 budget reflects the move of 13.59 FTE from our Senate Bill 118 funding, which ends on June 30th. And that would be, and also 9 additional staff that are scheduled to come off of our public health infrastructure grant are also included in, there's a shift from our grant funding to general fund. And then we do not have anything, any adjustment in for COLA or merit. And then we don't budget for payouts for retirees or people who exit employment. So that is something that our vacant positions or the gap between, someone leaving and someone coming on, that does help us cover that unbudgeted activity until we get further into the year and can do augmentation for those. General fund pharmacy, the medical supplies actually decreased from 28.4 million to 25 million. That is a decrease of 3.4 million or 12%. I believe this is somewhat related to the relationship with Gilead, with that activity not flowing through us, then we would have a decrease in that area. Any questions? Randy, I see your square went green. Okay.
No questions.
Next slide. Okay, for special revenue fund, again, it's similar to the revenue because revenue is driven by our expenses. So we have a decrease of the 8.9 million for Senate Bill 118 and our other lab expansion funding for 1.3 million. And then our PHI grant revenue for this activity is estimated at 6.1 million in fiscal year 27. And that is a total of 40.2 positions with estimated salaries and benefits of 5.1 million. And that grant, just if those 9 positions are currently scheduled to come from the grant onto general fund. And then the remainder are scheduled to be on that funding for the remainder of fiscal year 27. Next slide. The rest of these are just charts related to show you revenues and expenses by division, some with our cost allocation included, and then the next one. Next slide. And this one excludes our cost allocation so that you can see the natural revenues and expenses. Next slide. For personnel, again, we are anticipating that our fiscal 27 proposed is at 871.4, which matches our augmented budget. But you can see in the far right, we do have a change with some of those activities. We actually are moving the informatics positions that were previously in disease surveillance. You'll see on our organization chart. This is just a shift of those positions from disease surveillance to administration. That's the biggest shift, but it nets to 0 overall. And then the bottom part is actually to show the shift of FTE from fiscal year 26 to 27 between the special revenue fund and the general fund. And that is the 13.5 positions coming off of SB 118, as well as the 9 that will partial year will come over as well. And then we did have some increases, but overall net of 0 increase for the total FTE.
Chandra, do you have a question before we go further?
Yes. So just for clarity's sake, when those folks come off of SB, I'm sorry, I'm losing the number. That is a grant, correct?
It's an interlocal. It's funding from the state under the Senate Bill 118 from 2 years ago. This is our second year.
Kind of a one-time shot, though, right?
Right. So for that funding, and then state public health fund did come in this current year, and it actually bridges for next year. And that funding, these positions couldn't go on to that because we had already assigned other activity to those funds.
So these are, just for clarity, these are PERS positions that had were funded by a grant for a period of time, but now they have to go back to reality, which is out of our regular funding to support those PERS positions.
Yes. They will.
DJ, though, for a little more clarity, maybe you could tell her the history. So those positions were people that actually we had lost federal grants that we moved them into, so we didn't have to lay them off. And that first dash of money was one-time money from the legislature. Last session, we were successful getting the second bill, so then we could move those folks over, right? So we never want to try and lay anybody off. And that was the way we were able to keep them on that initial grant, is because we would have had to lay off. I think at one time we talked about 40 people or something. Is that correct?
Commissioner Kirkpatrick is correct. Still trap memory there, and that's right. And that's why you see initially when the COVID and ELC dollars sort of went away and those grants ended, We're very grateful for SB 118, which allowed us to retain some of the capacity to do the investigations that were in place with some of the disease surveillance team and laboratory staff. So you see some shrinkage in community health and disease surveillance as well. So that's right. It was more of a retention opportunity, one-time infusion, 2 years.
But just for clarity's sake, we're in a better position financially to be able to absorb those in our regular general fund. If I'm understanding because I agree, look, we need disease for surveillance. We love having a staffed organization. I'm just for clarity, making sure that we can do this, and we can do this not just for 1 year, but for going forward.
So I'll have a slide that shows the impact on the general fund in a couple of slides of all of the activity, not just these. But so the 13.5 positions, those would be, and that was an expiring grant, and that it had a natural end to it. So when we lost the ELC funding, what came onto our state public health fund was some of the positions that lost funding from those. So this is the first wave of FTE coming back onto the general fund. So having the vacant positions helps us there, because now we do have the capacity to bring these on. So then I think in future, what we would be looking at is, if public health infrastructure grant, on the prior slide, I showed that we have 40 positions on that funding. When that funding terminates, if there's not a second round, then that would be in addition to these positions coming onto the general fund. So that's probably where we would have to have a conversation about what impact we can have on the general fund.
DJ, I don't think you answered the councilwoman's question. I think you talked in a lingo that I didn't get myself. So is the answer, we're good with this going forward, and then should anything change, we have to reevaluate it?
That is the answer.
Okay, thank you. I'm sorry, Councilwoman. You wanted clarity, so I wanted it clear.
I appreciate you.
I would say that every indicator that we get, if we get a termination of any of the grant funding, that conversation will have to have at each of those announcements, right? So if public health infrastructure grant were terminated early, that conversation would have to happen sooner. Right now, this budget does assume that funding is available for this full fiscal year, and I think it's actually through November of 2027. So just beyond this fiscal year.
Thank you.
Next slide. So with our capital fund, we have our total capital improvement projects for our amended budget were at 3.3 million. We're reducing that in fiscal year 27. The proposal is at 2.2 million. As you can see, that is across computer hardware and software was the major change. We had a large refresh in the 26 amended budget. And so that was not anticipated in the 27 budget. So that's the reduction. So right now we anticipate a smaller capital projects need for fiscal year 27 budget. And the 26 budget also includes in the improvements category, it does include the parking lot paving. And the 27 budget wouldn't. So there was a small reduction in the improvement section.
Okay.
Next slide. Okay, for our general fund, so this may help somewhat on the prior question. So our fiscal year 25 actual, our beginning fund balance was 54 million, and we had a net change in fund balance of 10.2 million for an ending fund balance at June 30th, 2025 of 65.1 million. Part of that, I would say that the unassigned portion of that ending fund balance, so I always have to bring that part forward, is 54 million of that fiscal year 25 actual number. And that would be the increase originally. Dr. Lockett had reported out in, I believe, January, that we had projected an actual deficit for fiscal year 25, but we had some things that happened in fiscal year 25 that turned that around and actually got us to be in a surplus activity. So we did not need to use the contingency that we had in that original amount. We did start the hiring freeze after we lost our ELC funding. So that contributed, I think it was almost for a full quarter. That happened in March. And so April, May, and June, we would have had the hiring freeze. And then we did have some true ups where we received almost $6 million in one-time money, some true ups with the pharmacy, and then the look back in our VAT. And so that did contribute to us having a better position at the end of fiscal year 25 than we had anticipated in our budget documents. In the 26 amended, we start with that ending fund balance from fiscal year 25. Our change in fund balance was projected to be $11.2 million reduction. And again, that 53 million, there are some activities in there that would bring that down for any assignment. So part of your fund balance, there might be inventory or committed funds, restrictions, encumbrances that would bring that number down as well. So the change in our fund balance is at 11.2 million. That would include all of the impacts of bringing positions from the grant funds onto the general fund. So in the long term, we will need to take into account all the things that Commissioner Kirkpatrick has been bringing up, which is, is our property tax going to flatten out? Is, what will our insurance increases look like? Those types of things too. So it's an ongoing conversation we're going to have about the availability of general fund to cover additional loss of grant funding if that is what comes to pass as we move forward. So then the fiscal year 27, we do start with our what we proposed in our amended budget to be the ending fund balance. And again, this change in fund balance, both of those do include, for the amended and the proposed, do include the $3 million contingency amount that we have. And I think, and then also for the general fund, it is the transfer that we do to the capital projects fund to cover that $2.5 million of capital.
So DJ, it looks like it's structurally going the wrong direction and that we are going to run out of ending fund balance within a few years. How do you see this working its way out?
So that will be the management of our positions. We do carry the vacant positions, and I think it's a matter of if we continue to get the PHI the infrastructure grant to manage those 40.2 positions within that. So it right now it's hard because we don't know what's going to expire. Not sure if the funding that we receive for through state public health funding, if that is a one-time funding source. So right now, I think that's why we continue with hiring freeze so we learn more about what our funding sources are going to be as we move forward. So, but yes, right now, that's the, with the contingency, so, you know, we have cumulative, there's $6 million in that number that is related to a contingency of if we have to expend additional funding. So it could be, and then manage other expenditures.
Well, it just looks like we're going to get to a point where we're going to have to make some changes and make some hard decisions, it looks like. Coming up pretty soon, unless the funding continues, other sources of funding in terms of grants and so forth changes or it continues. So, all right. Thank you.
Next slide. In our special revenue funds, our expenditures, this should be for our grant funding. It should be a net impact, right? So our expenditures drive what we get, should be what we're anticipating for revenue. In the expenditures, the revenue other, there is a transfer that occurs between the general fund and the special revenue fund for the difference in our cost allocation and our indirects. The de minimis amount that we claim is 15%, but our cost allocation is at 25%. So our general fund transfers the funds to cover that differential for the special revenue funds. Next slide. Capital projects funds, again, looking at our fund balance. So we do transfer in for what we anticipate. So there is a anticipated to be about a $3.7 million ending fund balance. So it grows slightly. The amended budget did include the increase for the increased cost in the paving project. So we're hoping that stays static as well. Next slide. This is the bond reserve fund. There's not a lot of activity other than we do receive interest revenue in the bond reserve fund just based on the investment of these fundings. Next slide.
Hold on, DJ, we have a question. Nancy, do you have a question?
Oh, sorry.
Yeah, I do, and I'm sorry, this is a couple of slides back. I guess I share Scott's concern that our ending fund balance is a little alarming. So I was just wondering, I've only been on the board 3 years. Can you, not today, but share, when was the last time that our ending fund balance was that low, or just, sort of the decline year over year? Because I'd like to, if we've sort of been in this spot before and, we know how to weather the storm, or we have experience of making, hard decisions, I would just love to have more context, because it is kind of, I do want to be proactive. So.
Right, and I believe that we do have, so the required fund balance, I think, is 16.67%. And at the 33 million that we had anticipated, the 39 million, that would still be at 31% fund balance. So I'm sorry.
Okay.
That's fine. So right now, I believe our fund balance requirement is at 16.67%. So even with the reduction, we are higher than that. So do remember that we do not include any COLA or merit increases in the budget that you're seeing right now. So that would also impact that bottom line as well once we include that after we're get through negotiations and know what those amounts are. So right now, I believe there may be people on the call that were were here at the time that we had a reduced fund balance. And I do believe that there were layoffs and reductions at that time. And I see Marilyn's hand up.
Yeah,
Yes, go ahead,
so
Marilyn.
just for a little historical, I feel like the freaking History Channel at Clark County these days, I swear. But just for a little historical, the last time we went into negotiations, we were projected at this point to be at a 9% or 10% ending fund balance. So the law says that we can go below 16%, but we have to do a resolution by the board. But we've always been relatively conservative because when Scott and I came on the board, they hadn't balanced a checkbook for at least 4 or 5 years, right, Scott? So we feel very confident with DJ, though, that a 16% ending fund balance is a good place to be. We're not necessarily trying to be in the 30% or the 10% because we need to give services and we need to have a sustainable. So I applaud you for DJ has been here for what, 4 years now, maybe going on. But you've always been at the health district within a spot, but we really dug ourselves out of a hole for a sustainable long-term plan. So I just caution that we just have to be mindful, and usually our employees understand and they're normally watching this to see where our balance is, right? So we are pretty close on our projections. I think we succeeded where we were expected to go if things didn't work out. Dr. Lockett, that was one of the first things that you did was help with negotiations last time, and we managed to save. The big thing I think we all have to worry about is HR1. We don't know what's going to happen with that. We don't know how many grants are going to come and go, but I feel pretty comfortable that we're in a solid spot today and that our employees and the services that we offer can stay the way they are. But of course, everybody just has to be a little more on edge this time as in the past, right? So I can't forget who the person was who's no longer with us, but he insisted, right, Scott, that we be at a 25% ending fund balance, and we said, nope, that's not what the law says. And then we went a little further to say, okay, well, we'll be at 14 if we have to, because our employees are feeling it too. But at the same time, to be at 16 means that we're above where we anticipated being at this point with everything that we did, and no layoffs. We didn't have any layoffs, which I think is key.
Yeah.
Is that a fair assessment, Scott?
Yes, and I think just, once again, with some historical perspective, prior to the pandemic, we ran, a much lower ending fund balance as a percentage. And that was something we would keep a very close eye on. But then during the pandemic, you had a lot of different things going on in terms of grants and all that sort of thing. I think that then, as we're coming out of that and now getting kind of more back to a normalized kind of financial situation, I think that ending fund balance is trending down. And so what I'm concerned about is the trend, but I think that it's a natural trend, but it's something that we need to focus on and keep an eye on as we move forward with negotiations with, the team members and so forth. So that was just kind of my point in terms of the trend of where we're headed. So does that all make sense, DJ?
Absolutely. And I think part of what can contribute to that is we lost the ELC funding, and we have had a hiring freeze. I think we do backfill some positions, but overall that large group of vacant positions has been frozen, and it's with careful consideration when we fill positions. But also, I think we are very attuned to the activities. Dr. Lockett brings back information about the potential for grants. And so we are always running numbers out of these budget numbers to say, what is that impact if that were to cease? And I think it does feel a little bit like a roller coaster, because we will get a notice that something's happening, and then it reverses and we move forward. But we are very data driven on making sure that we know what the impact of all of those individual pieces are. So yeah, we're definitely
So
stay on top.
DJ, another point you should probably make is at one point during COVID, we were at over 70% of our dollars were grant funded, and this finance board directed you to get more in line with the 50%, which I think we've done so that we're not so self-reliant. Isn't that also correct?
Yeah, our grants are definitely going down. Our CFA, well, our direct grants were 64, and I think this budget has us at 45. So it's definitely been a downward trend. The COVID grants are definitely contributing to that. So yes, we are. I think when I first got here, our police salaries were at like a 69-31 split, general fund, special revenue fund. And so I think we're closer to 63-37. So yeah, it's definitely, our grant funding is definitely coming down in comparison to where it was when I got here in the year before.
Okay, let's move forward.
Okay. Next slide, I think that might be the end of the presentation.
Okay. Are there any additional questions from the committee members? If not, I'd ask for a motion to receive the fiscal year 2027 budget and recommend its approval to the board.
So moved.
We have a motion. Is there a second?
Second.
We have a second. All in favor, say aye.
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 I
Thank you. That passes. Next item on the agenda is item number 5, to receive and discuss the financial report as of December 31st, 2025. This is, DJ, this is an informational item, not an action item. Is that correct?
Correct. I think it goes into the board meeting as an informational item.
Okay.
Sure. So, okay. So quarterly we bring the financial statements forward unaudited, just to give an idea of what our standing is. So our revenues, our general fund revenues, which is our property taxes, charges for services from our clinical areas, licenses and permits for EH. We're at 69.37 compared to a 60.79 budget, and that's 8.58 million favorable variance. So on this slide, I will go ahead and remind everyone that environmental health, we do our initial billing on July 1st, and that is 70% of their income. So we record that all on the front end, and so it does skew the numbers for a while. And then we have another billing in January. So the special revenue funds, we were at 22.0 compared to a budget of 30.9. That's an unfavorable variance of 8.86 million. So you can see the two kind of flatten each other out for the revenue side. On the salaries, taxes, and benefits, we were at 53.16 million compared to a budget of 55.75. So we do have a favorable variance there of 2.59 million. Our other operating expenses at 30.22 million compared to 38.24 million. And so some of this you'll see in the subsequent slides is related to some of our vaccine expenditures, some in our pharmacy. They are not expending as much as we would anticipated at that period. So our total expense is 83.38 million compared to 93.99. So that is a favorable variance of 10.61 million. So our net position is 8.07 positive. That would be compared to a budget that we would have expected at 12/31 of 2.26 million. So it's actually a positive variance of 10.33 million. Next slide. So here's some of the details of where our revenues are coming In administration, our variance is 2.1 million. This is from our adopted budget. We did get the additional property tax funds that when we compare the March financials to the augmented budget, that will come back into alignment. And then you can see environmental health, of course, they are budget at 6 months through the year would be 14.9 million. Of course, the 22 million is because of the major portion of their revenue coming in so early in the year. And then you'll see on note 2 under our grants, the underspend in the administration category is related to our lab expansion. A lot of that activity is going to happen in this upcoming the second half of the year, so that will come in and also come into alignment as well. And then the FQHC, that is, we did have a grant that we included in the adopted budget that did not culminate. So we do have an adjustment to that when we do the augmentation to take care of that difference. Next slide. Okay, and then this is just revenues by category. It shows by division and the type of revenue that is generated. Chandra?
Yeah, Chandra, go ahead with your question.
Thank you so much. So you said that you have another augmentation of the budget later to deal with the anticipated bad debt that we will write off. How does this affect the budget? Does the augmentation usually increase the unfavorable, I don't know what the term is you used, increase the debt to income ratio to a point where it becomes unfavorable? So if we had the same write-off amount this year, so you added 2 or 3% for inflation, how would that affect the overall budget and the unfavorable, I don't know, what's the term you used?
Unfavorable variance, sorry.
Yes, variance, yes, thank you.
Yeah, so our write-offs will actually come in under our charges for services revenue category. When we talk about the augmentation, that's when we reevaluate what we put in our adopted budget. So the budget that's included in this set of financial statements, because we just got the augmentation that the first augmentation approved last month, it's not included in this activity. So the augmentation is really for us to align more in alignment with what our actuals are. So if we see that in case like environmental health, we have, if their budget is 29 million and we have 22 million here, then in the augmentation process, they would actually look at that and reproject to be more in alignment with what they anticipate having by June 30th. And so the March financials will go against the augmented budget that was approved last month. And then in June, we have another chance at it to make sure that we refine the budget to be more in alignment with what we think our actuals are. And we do watch to see if there's any big adjustments that we need to be aware of.
So if I'm hearing you correctly, there's a little bit of leeway already in the budget to sort of anticipate some of these things. And then the augmentation is the official checkbook check for us mid-year.
Okay, so could you go back a slide? So in the case of under administration, what gets recorded there as revenue is property tax. And so we know that our adopted budget, the 21.698 million, that was before we received our actual the final allocation, just because of the way it was timed. And so we know that number we will adjust up to the actual number, which will be the 2.1 million. But there's the other side of that, which if we look at, not picking on anybody in particular, but if we look at like the FQHC, we would have to look at why they are, their budget is 19.5 million, but their actuals are 18.4. So the adjustments can go either way. If we have, if we have a lot of, for PPC, if we have a large volume of our back to school happens in this fiscal year, then we would have the opportunity to adjust their revenue. So it really depends on, some of it is timing. And then environmental health, it would be, if they have, I don't know, another event that comes up and generates a lot of revenue, then they would be able to include that in the augmentation. So it's really just refining the number so that we come in close. Our budget is sufficient to capture what we anticipate for our actuals by June 30th. So here, yeah, when you look at this, you would see the 2.1 million on that first line. And that is strictly because of timing. We only had the expected number, not the final number, and then it actually went up by 2.1 million. So augmentation is really to align our budgets to what we expect our actual performance to be by June 30. Does that help at all?
Yes, for the true up portion, yes, but not for, I don't think I got a clear answer about reserves or elasticity in the budget to anticipate what we know happens each year, like the FQAC having to write off bad debt. Is that also already in the calculus, that if there's room there for the bad debt to be written off, and you base that on previous years bad debt write-off, and you sort of pad the budget so that you have that without going over the budget and having to move money from another department into HQAC?
No, this should be in there. That should consider the bad debt write-off. In the original numbers, it's just a matter of if our patient encounters are more in the uninsured area than the insured area, it could impact the revenue piece or the type of encounter we have. And so that part is, I think, Randy and his group on that revenue projection.
So DJ, I understand what the councilwoman is saying, but I think that so state law allows us to do augmentations a couple times a year, right? To constantly be truing up our books. So the councilwoman, I think, is asking, have we factored into many of those outlined things? And the answer is yes, which is why we have an ending fund balance of 16.6%, which is also why we do quarterly updates so that we can stay on top of it, so we can adjust if we need be. And so that sometimes is a hiring freeze. That is maybe not filling those vacancies that we had put out there, right? That is maybe not doing that capital project and kind of pushing it along. So I think I don't want to speak for you today, but I feel like the short answer is yes, we do look at all that, and we do give a little bit extra just to ensure that we have the flexibility, which is why state law requires us to have a minimum of 16.6%, because it's supposed to be an operating amount in the event that something stops, right?
Yeah, these reports, we asked for these because we didn't want to go to the end of the year and then be surprised, right? So that's why we asked for these quarterly updates. And obviously, when you adopt a budget, a lot of it is projecting where you're going to be, and then the augmentations are required because we are required by state law to have augmentations so that we're not spending money or using money that we haven't included in the budget. And so that is the true up where you actually show your actuals as opposed to what was projected in the budget. Chandra, to your question though, those write-offs and so forth, that should be, that as best they possibly can, included in that line item for FQHC.
Thank you.
And Randy and his group work on that modeling, and we have to refine it depending on what changes in our structure. Yes, you see these quarterly. All the other people see them monthly.
Thank you.
Next slide, and then the next one. These are just the definitions of what's contained in each of the categories. Next slide. Okay, then on the expense side, again, on the big discrepancy is under admin, under supplies, contractual, and capital. And again, that is related to the lab expansion expenses should be coming in. This is consolidated general fund and special revenue funds. And then on number 2, the public health and preventive care, we do have a variance there. And some of that is our vaccine expenses. So the budget we present here is the total budget divided by 12. So it would definitely have an impact. Timing will have an impact. Back to school under that particular one will have an impact because they may actually have higher expense in the last 3 months of the year than they do in the intervening 6 months. And then our transfers out are under that is very much related to our indirect costs. So if our grant funds are lower, which they are, then it won't pull as much for the transfers to cover those indirect costs. Expenses by category, by division, just for information. Next slide. Your definitions again. And then next slide. Okay, and then we did bring the capital and bond reserve. We showed that in the fiscal year 27 budget presentation, but this is just to show their activity as well, to show our transfers have occurred, and then our facilities. Again, we do have the parking lot pavement is part of that budget. And so our actuals to date are fairly low in this area. And then IT is usually throughout the year. And I think we may have an AV project in there as well that will come in the next few months. Next slide. And then this is just a summary kind of in the format of how our audit looks. So we have our total assets, the general fund, special revenue, the other governmental funds are the debt service and the capital projects fund. So it does follow the format of our audit. And then our total liabilities. And then this is the part where we follows the non-spendable part. So if we have inventories, that's not spendable. So we restrict that out of our fund balance. Our committed is the emergency fund that was set up by the board. Our assigned is any encumbrances we have that are not reflected in our liabilities. And that does include the $3 million contingency that we had established in the June 30 financials as well. So the unassigned amount for, in this case, the general fund is $54.5 million, which is reflective of the number that we were looking at as our, it's actually very close to our June 30 number as well. So the thing I have to point out, because we do have the reconciliation in our audit, so we do have activity that's not recorded in our fund accounting, and that is our compensated absences, our pension liability, our leases and subscription, all the GASB related activities that they're not included in here, but they do result that if we did net all of that against our fund balance of the 79 million, it would be a negative of 27.4 million. And that's actually a smaller negative number than how we ended with our audit. And a lot of that is because of that EH revenue on the front end is helping with that. So that, I think, next slide. Oh, questions?
All right. Do any of the committee members have any questions? Thank you for the presentation. I think that concludes the section 6 of the agenda. Next item is section 7, which is the second public comment period. It's a period devoted to comments by the general public and discussion of those comments about matters relevant to the board's jurisdiction. Andrea, do we have anybody to make public comment?
No, there's no one online for public comment.
Great. With that, we'll close the second public comment period and we'll move to adjournment. We're adjourned. Thank you all.
Thank you.
Thank you.
Appreciate it.
Thank you.
Good
All right.
night.
Thank you.
Good night. Bye-bye.